Gardasil is a quadrivalent HPV vaccine, providing protective immunity against HPV type 6, 11, 16 and 18. You will no doubt be familiar with the National HPV Immunisation Strategy, which aims to provide a vaccine for girls aged between 12 and 17. What you may not be so familiar with is that the product licence actually includes other age groups, but it may be the case that you come across individuals who've accessed the vaccine by other routes. The aim of this programme is to vaccinate all girls between the ages of 12 and 13 to provide them with protection against HPV. There is a catch-up programme that allows for vaccination up to the age of 18 for those girls who've missed their original vaccine or failed to complete a course. The vaccine for this programme is supplied by the national provider Movianto for the Department of Health. It's very important the vaccine obtained through this source is not used for indications outside of the national vaccine programme. The process for catch-up is going to be coordinated through school nurses and general practitioners. Additional supplies of vaccine for these individuals can be ordered through the DOH supplier Movianto. So how is Gardasil given? The vaccine is given as 3 intramuscular doses at 0, 2 and 6 months. As you'll see from this graphic, there's a considerable degree of flexibility for the dosage schedule. The second dose of the vaccine can be given up to a month early, but it is important to ensure that there are 3 months between doses 2 and 3 of the vaccine. It's very important to ensure that all 3 doses of the vaccine are given to each patient. This will help to ensure that they receive the maximum protection against human papillomaviruses. Some of our patients and their parents are concerned about the safety of vaccines. So what can our patients expect? Like many vaccines, local reactions are quite common, particularly after the 2nd or 3rd dose. More significant local reactions like bruising, fever, nausea or headaches are common. Serious sensitivities, such as those listed on the right-hand side of this table, are rare. So let's look at protection against cervical cancer. Cervical cancer requires HPV infection to develop. On the way to getting cancer, individuals will pass through a series of pre-cancer stages known as cervical intraepithelial neoplasia. In studies of HPV vaccines, we choose to look for protection against the severest forms of precancer, namely CIN2 and 3. It would not be reasonable for us to wait for individuals to develop cancer, as effective treatments exist for these severe forms of the precancer change. Using data, we can see that Gardasil provides 98% protection for CIN2 or 3 lesions caused by HPV type 16 and 18. But precancer changes are not limited solely to the cervix. They can affect the tissue of the vagina and vulva. These are known as VAIN and VIN respectively. In studies, Gardasil appears to have 100% efficacy in protecting against the development of high-grade VAIN or VIN. It's important to stress that this high level of vaccine efficacy will depend upon the correct administration of 3 doses of the vaccine and in trying to extend the coverage of the vaccine to as many suitable individuals as possible. So Gardasil has good efficacy against the development of severe precancer of the cervix. But that's not the whole story. The vaccine is a quadrivalent preparation and contains an immune message against the infection with HPV type 6 and 11. These types are the major cause of genital warts. Studies of the Gardasil vaccine in patients between the ages of 16 and 26 years have shown high efficacy for the protection against the development of genital warts. Looking at this graphic, you'll see that these studies were not limited to women alone and that men also benefited from the high vaccine efficacy. So what about the real-world effect of the vaccine? This graph is using data from a population-based vaccination programme in the state of Victoria, Australia. This programme aimed to vaccinate girls between 12 and 18 and started in 2007. You'll see on the left of the graph the baseline pre-vaccination rates for girls under 18. Following the introduction of the vaccine in 2007, there was a sharp decline in the incidence of high-grade smears in this age group. In the United Kingdom, smears do not start before age 25. However, this study provides us with some hope for what we might expect in our screening programme in the future. A second study looked at the effect of vaccination on the development of genital warts. This study looked at 53,000 attenders to sexual health clinics in Melbourne. You'll see from the graph that following the introduction of the vaccine in 2007, there was a dramatic fall in the incidence of genital warts in patients attending these clinics. If we look at the incidence of warts during this period for patients aged over 30, i.e. those patients who would not have been exposed to the gardasil vaccine, the incidence did not change, suggesting that this is not a general decline in the incidence of warts. So how long does this protection last? At the time of licensing, protection had been clearly demonstrated up to 4 years. Peptide vaccines work by inducing immune memory via B cells. Studies that have looked at subsequent doses, i.e. after the 4-year period, show an increase in immune responses following a booster vaccine. This would suggest that gardasil is indeed inducing immune memory. It remains to be seen how long the protective effect of gardasil will last. Studies are ongoing and will provide us with this information in the future,